Live streamed Twitch, yo. No, all right, so any questions to begin with before I let those few people log in? No questions? You guys are all antibiotic experts and derm experts and ENT, absolutely. I just feel the confidence in being exuded off of you. All right, anyone else I'm waiting on to log in? All right, we'll go with 61 then. Guess there's a few team players here. Cheaters. I hope I keyed these correctly. I was doing this yesterday, but we'll see. Okay, a patient with a penicillin allergy would be contraindicated from receiving which medication? Good job, yeah, absolutely. So remember that piperacillin still falls within like kind of the penicillin umbrella. So certainly that will be considered, it will cross-react if you had a patient with a true penicillin allergy. So I would not want to give them Zosyn. But Astrinan, what type of antibiotic was that? It's monobactam. So that one actually had, one of its claim to fame for a while was that, yeah, there's no cross-reactivity, so you can certainly give that. And then the other two being cephalosporins, we know that has a very, very low likelihood of cross-reactivity. We're safe to go ahead and give that if the patient had a true type 1 allergy to penicillins, right? So it's not just diarrhea, it's not just vomiting, like it has to be a true allergy there. Perfect. I guess we're off to a good start. Which fungal infection would require the longest treatment time? Should be pretty quick. Yeah, so the toenails tend to be the longest treatment time. Some of them can take like up to a year in some cases to treat. High failure rate, because again, think about where your feet are typically, in your shoes where it's nice and warm and dark and moist, and that's where fungus like to grow, right? So toenails are difficult to treat, usually require the longest treatment time. Awesome. You diagnose a patient with viral rhinosinusitis. Which treatment would be appropriate? So we're getting all the easy ones out of the way first. Absolutely. All right, so again, can we really do anything to treat a lot of those kind of ENT viral illnesses? Not typically, right? A lot of them like adenoviruses and things like that, you can't really do anything for them. You can do supportive care, certainly, but when would we use things like valacyclovir, acyclovir? Yeah, HSV typically is where we're going to be using that most likely. Right, and then Foscarant's one of those ones we like to hold off as long as we can because those are really pretty toxic, cause a lot of electrolyte abnormalities and some renal issues and whatnot. So we don't like that one. But yeah, supportive care. And again, this is what a lot of your patients are going to need. But when they come into you, what are they going to want to get? They want antibiotics. They want a prescription. But you have to hold fast and say, nope, you are not going to get any. Press Gainey scores, be darned. Okay. Which of the following antifungals blocks CYP3A4 activity? Wow, quite a spread there. Okay, so fluconazole, right? So go back to the mechanism of action, right? How does fluconazole work? Yeah, so it works on the fungal wall, cell membrane, kind of that whole area, right? There's increasing permeability. But more specifically, how does it work? yeah, so I was working on the fungal CYP P450 system, right? So again, there's some cross reactivity there where it can interact with our CYP enzymes as well, not just the fungal cell wall, which is, they use those CYP enzymes to produce their cell wall versus us, we were using as, drug metabolizing enzymes. So the azoles as a group, they tend to block CYP3A4 activity, which is why they see so many drug interactions that come about from those drugs. This is why it's super important that you look up those interactions beforehand, especially when we have things like posaconazole or like ketoconazole, itraconazole. The thing we run into a lot, especially our pediatric cancer patients, is that they're on so many different medications. They're immunosuppressed, they end up getting a fungal infection, and all of a sudden we have to treat them with one of these drugs. It usually ends up affecting 3 or 4 of their other medications, which can predispose them to some pretty significant adverse effects from having those levels increase, right? Because as I inhibit CYP3A4, drug levels that are affected should go up, typically. Griseofulvin, how did that one work? Yeah, by doing what? Yeah, so messing with those microtubules, right? So kind of preventing cell division. Amphotericin B, do you guys remember how that one worked? Yeah, so it kind of disrupts the cell membrane kind of directly. Again, that one is also one we like to hold off. It's more for invasive kind of fungal infections because, again, the nickname for that one is amphotericin B for a long time. We don't like that because it caused so many side effects associated with it. But fluconazole is kind of a good bread and butter kind of antifungal that you'll use in a lot of cases. Again, this is going to be more clinically relevant with oral administration or IV administration. There's some cases where you may use more kind of local administration, like they have like diflucan, like vaginal tablets. So sometimes you can see some vaginal infections being treated with that, but that would be more local effect. Really wouldn't see a ton of systemic issues pop up. So again, kind of keep the context in mind. All right, which of the following medications can prolong the QTC interval? I know people love the carbapenems, but don't use them. Hold them off. Save them for a special occasion. These are good side effects to know for specific classes of drugs. It's kind of one of those buzzwords like CYP3A4 inhibitor or inducer, like QTC prolongation is a big one. Yes, sir. In some cases, you will find that drugs will get a black box warning for QT prolongation. So, for instance, I think Zofran or ondansetron, it's a very popular antiemetic drug. That one recently, within the past couple of years, got a black box warning people about the QT prolongation you see with that. So it's not always, but if it's a particular concern or if they've had like a kind of an outbreak of adverse effects due to that, that's sometimes what will be the impetus to a drug getting a black box warning. Which one is what? Which one's more black box? I'd have to look. We can look it up actually. Let's look it up. Let's do it. So you can see there's multiple black box warnings on a lot of these on these medications. So for instance, we look at levofloxacin.
I think the question had said that which one would you educate your patient on that was a black box warning?
Well, hold on. So let's look this up. I see what you're getting at now. I would appreciate if you don't use this as ammo against other potential faculties. Okay, so let's look at the black box warning. All right, let's see. These have been associated with disabling and potentially irreversible serious adverse effects, including tendinitis and tendon rupture, peripheral neuropathy, and CNS effects. So see, with this one in particular, does not get a QT prolongation black box warning. It does have one for tendinitis, but did not have QTC prolongation. So just because something causes QT prolongation does not mean that it's going to get a black box warning for it. You should still be aware of it because it's still important. So if we were to go to, like, say, adverse effects, cardiovascular, see, there's just kind of the most common ones I'll list here. And here you go, prolonged QT interval on ECG. So So does that make sense for everyone? I'm sorry if I cannot justify a give back on a test for you. Okay. So anyway, so getting back to the question at hand. So again, what classification does sclerothromycin go into? Macrolides. So those ones as a group tend to cause QT prolongation. Azithromycin, erythromycin. So watch out for those guys. Note also they have that CYP inhibition effect, which you do see some CYP inhibition along with Bactrim as well, but that tends to be usually like 2C9, 2C19, kind of the 2C family of CYP enzymes with Bactrim, right? Really no big issues with clindamycin or ampicillin there. So again, keep those kind of unique side effects in mind when you're kind of studying these classes of drugs, right? Okay. That's funny, Pseudomonas. I like that. Which medication is most likely to cause sedation as a side effect? All right. Good. That's good. Right. So, what is the distinction here between these this group of medications? First generation versus second generation antihistamines, right? And these are blocking which histamine receptor? H1, absolutely. So, note that the first generation antihistamines, they can get into the blood-brain barrier, they can cross that, get into the CNS, and that's where you see a lot of those effects, right? You see the sedation, you see the anti-emetic properties, anti-kind of vertigo properties. All of that comes back from the fact that it can cross the blood-brain barrier. The second generations were designed to not cross the blood-brain barrier, and thus you lack a lot of those central the CNS effects. So you end up seeing less sedation, but you get kind of the good peripheral effects that you're looking for. So think loratadine, fexofenadine, cetirizine. Those are your three go-to second generation antihistamines. Again, these are very common ones, especially now that they're all over the counter. A lot of your patients are going to be using these. So keep in mind, which ones might be better. So for instance, if I had a patient who's having, say, seasonal allergies, and I knew that they were, say, like they worked at the airport as like a flight controller, like you probably don't want them to be too sedated, right? You probably want them to be awake to direct flights appropriately. So you would recommend probably a second generation antihistamine. I will say out of the bunch, cetirizine is probably a little more likely to cause sedation out of that group. It tends to be a little bit more effective. That's just kind of anecdotal kind of experience, but in general, you don't see nearly the amount of sedation as you would with like a Benadryl or a Phenergan or something like that. Does that make sense? Okay. And again, like oftentimes when people are abusing these drugs, they're usually abusing the first generation ones because those are the ones that, at lower doses cause sedation, but then at higher doses you start to see more of the anticholinergic effects and they get very agitated. They start to have hallucinations. They get pretty high off of that. Actually, I don't know if I ever told the story, but I had one kid who came in after a party. And remember I mentioned that triple C's? The quercetin cough and cold contains that chlorpheniramine in there, and they do plates of them at a time. So if you imagine pulling out a box with like a blister pack, they would do one whole plate at a time with those, just kind of pop them out and ingest them. He had done 2 of those, never had done it before, and came in having very severe agitation, hallucinations, ended up having a seizure. We ended up having to give him a benzodiazepine to treat the seizure. So you guys are familiar with any benzodiazepines? We haven't covered them in this class yet, but Xanax is one. Usually use that for like kind of oral outpatient management, but we have like Ativan, lorazepam, we have midazolam or Versed. So we ended up having to give this kid quite a bit. Normal seizure, I can treat that with like 2 milligrams of Ativan. This kid needed 14 milligrams just to put him asleep, right? Just so where he was still breathing, but he was still having some fasciculation, but he was at least not like actively combative against the staff. So this stuff can be very, very dangerous, especially when you have teenagers that don't really have a whole lot of sense and way too much time on their hands. So be aware of that. Okay. What's the name of this character? This is just fun. My Nintendo kids should know. Very nice. The two people who said Jigglypuff, you can get out. Never knew it wasn't Princess Peach. That's pretty good. Okay, moving on. No points for that one. That was just fun. Which dosage form would be most occlusive when administered topically? Try to interject a little bit of fun, because otherwise you guys get way too serious like this. A little too quiet.
So you don't necessarily mean that needs to be with an occlusive dressing. You mean
the dosage form itself is occlusive.
Oh, okay.
Mm-hmm. Careful not to read too much into the questions. You know, students will come up afterwards after a test and be like, well, I read it as this, and I was like, well, what did it say? It said this. Okay, so why didn't you answer based off that? Well, I thought you meant just read what the question says. That's all you got to do. Perfect. Yeah, so ointments tend to be the most occlusive, right? Those are going to have like the highest oil content, so those tend to stick around the most. Those are the most kind of greasy feeling. And again, if you imagine like touching, some, animal fat or something, like you feel that greasy feeling on your fingers for a while until you wash it off. So again, those tend to be the most occlusive. And what type of skin would you want to put that on, most likely? Yeah, so more dry skin is kind of what I was getting at. But yeah, certainly if you have more occlusive dosage forms being given into thinner skinned areas or those kind of aeruginosa areas, like those tend to have better absorption of drug there. So you kind of keep those facts in mind. But again, when choosing what type of product you want to use for your patient, it's important to decide what you're going to do based on their experiences. So like I just did a site visit at a derm site yesterday, and I was talking to the student, and she had a patient who's coming in. They're having like really bad scaling, lichenification of the skin, so they end up using, I think they end up using a lotion for them because it tended to be very hydrating, and it had the right drug in it they were using to treat that patient's psoriasis. So again, this stuff does come up in practice. As much as you might want to repress this information after you leave the test exam room, like you should remember that.
Good question. Where do gels fall within that?
A lot of them tend to be more alcohol based, and so they tend to be a little bit more drying, but you're probably not as hydrating as like a lotion, but not as bad as like an aerosol or some kind of alcohol based spray or something like that. Yeah.
So, would you use something like something that's oily based? Like an oily topical issue?
For those, if they tend to be, you can use something that's a little bit more drying. If they tend to be really kind of, they're having kind of oozing, or if it's kind of more oily skin, like you can typically use something that's going to be a little bit more dry. That'd be fine, probably. Okay. All right. Which medication would have a relative contraindication in a patient with hypertension? Wow, it's quite a spread here. Okay, so key points to take away from this. So why does pseudoephedrine have a relative contraindication? It's gonna raise your blood pressure, right? Because how does pseudoephedrine working? Alpha activation, right? So it's activating those alpha receptors. But again, what kind of dosage form do you normally take pseudoephedrine in? Yeah, usually oral, right? So you're going to get full systemic effects from that. The benefit of using something like oxymetazoline is it's working much more locally. You don't see a ton of absorption from the nasal mucosa, especially when you're using a vasoconstrictor. That's actually one of the things we like about patients who, if they're going to do cocaine, it's nice when they do it if they're insufflating it or if they're snorting the powder, because it causes that local vasoconstriction, because cocaine's a, pretty potent vasoconstrictor. They actually limit how much of a dose they can absorb over time. It's not like if they're doing IV, if they're smoking it or something. Yeah, so oxymetazoline is relatively safe for those patients. You don't see a ton of kind of increase in blood pressure due to that. It's at least more safe than pseudoephedrine would be. And then how about Tylenol? That be okay to give? Certainly, yeah. And actually, in patients with hypertension, that's usually the go-to drug that we use for a lot of those patients, especially if it's not very well controlled hypertension. Because if I'd put, say, ibuprofen on there, would that have a relative contraindication? It'd be pretty relative in so far as, remember the effects that ibuprofen or other NSAIDs would have on the kidneys, right? So again, what are they doing to the kidney blood flow? They're typically decreasing, right? Because remember that afferent arteriole coming into the glomerulus, normally those prostaglandins are opening that up and being vasodilatory, right? If you have an NSAID come along, and NSAIDs do what to prostaglandins? Yeah, they decrease production, right? Because you're inhibiting that cyclooxygenase. So you're decreasing prostaglandin production. That tends to have a vasoconstrictive effect on the afferent arteriole. You're having less blood flow hitting to the glomerulus. The kidneys sense that. They sense less blood flow. And so what do they end up activating? The ROS system, right? So renin-angiotensin starts to get ramped up as a response to that, even though the pressure's fine in the body. In fact, they're probably too high to begin with. So in some cases, you can either see their hypertensive medications working less well, or they can raise their blood pressure mildly. So ibuprofen would be pretty relative, not as bad as like a pseudoephedrine would be, which is a direct vasoconstrictor. But Tylenol is usually going to be safe for most of those patients, right? So again, take all these factors into account. If I had a patient who had pre-existing liver dysfunction, which one would I might want to avoid? Yeah, you probably want to avoid Tylenol, right? Because again, that can patients who have pre-existing liver problems, they tend to have issues with Tylenol at lower doses than someone who had a healthy liver.
Just to check with Afrin, so I know it can cause hypertension, but it wouldn't be contraindicated in someone who has hypertension.
I would say it's safer if they have to use something. It would be safer than using like a pseudoephedrine, right? The effects would be much more minimal than you would see with a pseudoephedrine. Ideally, what you could do for those patients is to use what drug could you use instead that would have really no effects on their blood pressure? Use directly in the nose. Nasal corticosteroid, yeah, that would actually end up being the best thing that you could do for those patients. But again, think about how long it takes for those drugs to work. What would be faster acting, an Afrin or something like a Nasacort? Afrin works way faster because it's directly activating those alpha receptors versus corticosteroids that take a few days to a week or so to really kind of ramp up. So again, if you're thinking about, if it's just like a couple day thing, guy's coming down with a cold, he just needs to, I need to get up here and talk in front of you guys and I'm really just kind of stuffy, I can use Afrin and that's probably fine for a few days, right? You don't want to use it more than 3 to 5 days or so because what's the potential side effect you see with that? That rhinitis medicamentosa. You don't want to do that because you get that rebound hyperemia. So instead, what I could do if I know it's going to be kind of long-standing allergies, or if it's going to be something where I know that, hey, every fall, I'm going to have these issues, go ahead and get a prescription for that nasal steroid, and then you're good to go, right? Make sense? And your drug selection choices. All right. Tendinitis and possible tendon rupture. Oh, good thing we already looked this up. Why don't you get this one right? Should put is a black box warning for. All right. So ciprofloxacin is going to be the answer there, right? So think about the tendinitis, tendon rupture risk being strictly with the fluoroquinolones. There's probably a little bit higher risk in children, and that's why we try to avoid fluoroquinolones in that age group if we can. But you'll still see us use it. If you were to go to Nemours, there's probably a handful of kids that are on fluoroquinolones just because that's really the best drug we had for them. Clindamycin, you don't really see that. Clarithromycin, you wouldn't see that either. So again, look at those kind of unique side effects as being class specific. All right. Which test should be ordered before starting tazarotene in a 26-year-old female? Good. All right. So urine HCG is going to tell us what? Yeah, if she's going to be if she is pregnant or not. So that is the thing you want to check, because tazarotene is what type of drug? Yeah, it's a topical retinoid, right? So that's one of those things where even though it's topical, there still is some risk. You would probably want to go ahead and check to make sure that they are not pregnant before starting therapy, right? So it's usually recommended. Urine drug screen is not going to tell you a whole lot, right? CBC, LFT is probably not routinely recommended beforehand. Possibly if you're doing like more systemic therapy, maybe, but typically the urine HCG might be the only thing you need to order, right? Or unless you have a really good history. But again, how can you tell when a patient's lying? Their lips are moving, basically. So it's one of those things where they may not always be super forthright with you. You can imagine, like, you're interviewing like a 15-year-old patient of any gender, and you're like, hey, are you sexually active? Like, they're always gonna tell you no, right? But they're out there in sin, I tell you that much. Just kidding. Okay, alcohol avoidance should occur with patients taking which antibiotic? It's a classic kind of board question. All right, so to the two of you that picked linazolid, I'm very sorry. I probably should have keyed that as correct as well now that I'm thinking about it. I'll talk about why that is in a second. But metronidazole is a correct answer as well, right? So what reaction are you worried about? All right, what is a disulfiram reaction? The Asian flush? It can, yeah, rash for sure. Vomiting. Right, so what's the mechanism though? Yep, you're having a buildup of acetaldehyde because you're blocking the activity of acetaldehyde dehydrogenase, right? Remember, metabolism of alcohol is a two-step process. You have alcohol dehydrogenase converting it over to acetaldehyde. Then you have acetaldehyde dehydrogenase breaking it down. Eventually, it turns into carbon dioxide and water. But you miss that second step when you have something like disulfiram on board or metronidazole potentially. And so you can see that flushing reaction as it starts to build up, because acetaldehyde is really kind of a very uncomfortable kind of molecule. A lot of flushing, feel very hot, throwing up, just a very uncomfortable kind of feeling, right? Okay, why would linazolid have actually been a correct answer? Had I thought about it? You guys remember that tyramine reaction I mentioned? Right, so remember what enzyme can linazolid inhibit? Yeah, so the monoamine oxidase, right? So monoamine oxidase can be inhibited. Monoamine oxidase breaks down what? Serotonin. It also can break down just catecholamines in general, so epinephrine, dopamine, norepinephrine. So all those can be broken down by monoamine oxidase, right? So when you have a drug that inhibits that, anytime you have an increase in production of those catecholamines, those levels tend to rise because you're blocking the breakdown of them essentially. So if you have tyramine-containing foods, those can also increase that reaction because they will increase production of serotonin. So think like aged meats and cheeses, think red wine, think certain beers can have it in there. So technically that probably should have been correct. Yes, sir. Afrin would interact with MAOIs in the sense that they would be kind of synergistic in a way. So you'd have afrin that are activating alpha receptors kind of locally. Then you'd also have, if you had an monoamine oxidase inhibitor on board as well, that would also be increasing levels of those catecholamines. So again, you see kind of a synergistic action. This is more working on the kind of the kinetic side of it, where it's blocking breakdown of it, right, at that point. Make sense? Okay, so I'm sorry to the two of you. I don't have any way to compensate you, but that's okay. I'll give you a free answer as well for the test. Okay, which medication should be used to treat an acute otitis media in patients with a penicillin allergy? Which one should be used, not which one can be used? All right. So yes, Levaquin probably could work, right? But we want to hold off on that, right? Because again, you worry about increasing resistance to that drug over time. It's probably not the best kind of second line agent. You probably want to either use something like cephalosporin, or it could be another option. Yeah, like a macrolide, azithromycin or something would be another good option there as well. Linezolid really wouldn't cover any of the gram-negative stuff that could be potentially causative there, so that would certainly get strep pneumo, but it wouldn't get like your Marksala or H flu, things like that. Again, Levaquin's just too big of a gun to use for an acute otitis. So if we can kind of rear it in a little bit, use something like a ceftonir, that would be a good option, right? So again, you may find there's multiple drugs that can treat the infection, but there's usually one that is a little more correct than others, right? And so this goes back to medicine not being totally black and white. There's a lot of gray. So, you know, would you get sued for giving someone Levaquin in that case? Probably not, right? But it's probably not the best thing as far as just good practice goes. Okay, this is why we go back to our Sanford guides. We go back to our guidelines to kind of show us what should you use in those cases where you have a penicillin allergic patient. Okay. All right. Which of the following medications works to inhibit bacterial folate utilization? That's correct. Okay. So what's polymyxin B doing? Yeah, it's kind of directly disrupting the cell membrane. It's kind of like punching a hole through the membrane to cause it to start leaking its contents. Moxifloxacin is doing what? DNA gyrase, topoisomerase inhibition, azithromycin, protein synthesis inhibition, but sulfamethoxazole trimethoprim, remember those are working on two different steps of the folate pathway. So again, bacteria are not going to be able to generate new DNA because it's not able to make things like thymidine and whatnot, right? So there's going to be a few questions will be kind of just straightforward, like what's the mechanism of this drug, or which one of these is this type has this type of mechanism. There'll be a few questions like that. Those are kind of the easier, just rote memorization, but there'll certainly be more like the more kind of clinical ones where a patient is allergic to this. What can you go to next? Or they have this kind of disease state, and what would be the next option you could choose for that patient? Or they fail this, what do you go to next? Like those are kind of the questions that I like to ask because they are a little bit more kind of critical thinking, getting you in the mindset of, you know, what are your board questions going to look like? How do you actually treat patients? You know, these are things that I think are a little bit more important. All right. Who's got two thumbs and is totally going to rock this Pharm exam? It would have been good to have happen last, but. Hope everyone gets this right. All right, I also accepted me, duh, but yep. Those of you that answered blue or yellow, have confidence in yourself, or realize that there is a Pharm exam coming next week. And also an epibiotics, but we'll worry about that later. I know, right? Double whammy. Okay, which of the following is a potential adverse effect of using prednisone or deltazone? All right, pretty even spread there. Okay, so why would hypoglycemia not be correct? You see hyperglycemia, right? Because again, think about it as being kind of like similar to stress hormones in your body. When you have increased stress, like you want to be in a more fight or flight kind of situation, you want to increase glucose levels that are available to use for energy, right? So that would be hyperglycemia you'd see there. How about dehydration? You typically see fluid retention. That's back to the mineralocorticoid effects. Again, you're in a stress state. You want your blood pressure to be up so you can respond to threats, right? So hypertension would typically be occurring here. You typically see fluid overload. That's why you worry about this in like CHF patients who already have issues with fluid overload to begin with. They can tend to be kind of tip them over and potentially put them in an exacerbation. We'll talk more about that in the cardio section, but just be aware of these kind of disease states that these things will be interacting with, right? So diabetic patients, CHF patients, like these patients are going to have worsened effects due to things like prednisone, right? But viral infections, why would that occur? Weakens the immune system, right? So always be aware that they can suppress the immune system because these secondary infections occur. It doesn't have to be bacterial, could be fungal. You know, it just depends on the patient's situation, depends on how long they're on it for, and also what kind of dose they're on. You know, typically if you're treating for like a typical asthma exacerbation or something, you know, kind of short course, like less than a week, you don't necessarily need to worry about that so much. Certainly their, you know, blood pressure may go up a little bit, their blood sugar may go up a little bit, but it'll be temporary just while they're on the drug. And when should I taper a corticosteroid? Yeah, usually after 5 days or so. So if it's been more than a week, then I need to start tapering down because again, I need to give the adrenal gland time to really start to kick back up production. Okay. All right. Application of corticosteroids to which area would most likely lead to systemic effects? All right, so the axilla would be the correct answer here, right? Because again, it's the thinnest skin out of the bunch, right? So that would be most likely to have some systemic absorption, especially when you consider like the axilla, it's closed. You know, you're going to have a lot of occlusion there. Things that get absorbed better in those kind of situations. All right. Which medication is first-line therapy for a patient with strep pharyngitis? It's our go-to drug for the majority of patients. Again, it's not what could work to treat strep pharyngitis. What is the best choice? Right, amoxicillin is the go-to drug in this case, right? Because it is fairly narrow spectrum. You tend to have, you don't see a lot of resistance to amoxicillin. This is why we can continue to use it, right? Clindamycin certainly could get the job done, right? But You worry about things like C. diff colitis. You worry about, you want to save that one. It's not the first go-to for strep pharyngitis. Daptomycin, that could probably work too, but again, that's like using a freaking hydrogen bomb for to kill a cockroach or something, which they would survive anyway, so it doesn't really matter. Again, vancomycin, similarly, too big a gun. Amoxicillin is going to be perfect for this one, right? Right. Come on, guys, we got USA. Let's take out Russia, all right? Which medication would provide gram-positive and anaerobic coverage for a dog bite? So I think the I Heart Corgis person should be able to get this one correct. Corgis are quite vicious. All right. So things to note here. What does vancomycin cover? Gram-positive only, right? So it's only gram-positive killer. So I would not get our anaerobic coverage we need there, right? Really, the only anaerobic infection you'd ever use vanco for is what? C. diff, given PO, right? It has to be PO vancomycin. IV vancomycin does not work for C. diff, right? Tobramycin, what does that cover? Gram negatives, right? So it would not also have the coverage we need. Ampicillin probably kind of gives it away a little bit, having both these options here. But ampicillin, again, would not have good anaerobic coverage by itself, but by adding on what? Beta-lactamase inhibitor. Now we broaden out the coverage. Now it has good anaerobic coverage, and this is actually one of the kind of go-to drugs that we can use for like animal bites or human bites, things like that, because it has good anaerobic coverage, and we'll get those gram-positives as well. So it's usually our kind of go-to. Alternatively, if you wanted to use an oral medication, what could I use instead? Yeah, augmentin, so amoxicillin clavulanic acid, right? So depending on, if the patient is, needs to come in, because sometimes bites can be severe enough where they need to come inpatient, you might use something like a Unison, because that's primarily IV, versus if they were, say, managed outpatient, I can give them augmentin instead. Again, because they're both in that immunopenicillin class, they both have the beta-lactamase inhibitor, they tend to have similar coverage, right? When dealing with a time-dependent antibiotics, which of the following is true? Do you guys want the link to this afterwards? That way you can go back through it if you wanted to. Okay, I'll post that. Okay, right. So dosing decisions can be made from levels after one dose. Why is that incorrect? You're not at steady state. Yeah, so you need 4 to 5 half-lives before you can get to steady state. And usually one dose of a drug is not going to cut it. This is why we usually will check levels before the 3rd or 4th dose. That's typically been enough time for the patient to get to steady state, right? Because if you did that too early, you would think the levels are too low, and you would falsely increase, or you would incorrectly increase either the dose or the frequency, and that could lead to accumulation, lead to toxicity. See, post-antibiotic effect occurs when levels are above the MIC. Well, these don't really have post-antibiotic effect, right? It's more of a concentration-dependent thing. These have to be above the MIC in order to have any kind of effect, so they don't really have the post-antibiotic effect. Peak levels should be measured to assess efficacy. trough level is what we want to measure, right? Because otherwise we can get the peak really high, but we have no idea what the trough is going to be, and if it's above that MIC, it needs to be above that. So that would be incorrect. But these drugs often are going to be more requiring frequent dosing. So you'll see drugs given every 6 hours. Some of them be given via continuous infusion. It just depends on the dosing strategy. But they typically need to be given more often in order to maintain those levels above the MIC. Which medication is most likely to cause tinnitus as an adverse effect? Did I mention I had confirmation from an audiologist? He said tinnitus. That's why I started saying that. A lot of people say tinnitus, and I said it for a long time too, but he said tinnitus. I asked him. I was like, you got to solve this dispute for me in my head. And he said tinnitus. That's what an audiologist said, so I would trust him more than me. So.
Really?
Is it audiologist or otologist?
Huh?
Is it audiologist or otologist?
He was an audiologist.
Audiologist or otologist?
He was an audiologist. What?
You kept asking, I get it.
I got you. Took me a couple of times. I got it. It's early.
No, I get it.
Let me turn this up. All right, so aspirin, that's a kind of a unique side effect you see with aspirin. Some people have this at normal therapeutic dosing. You can they'll have that kind of ringing or kind of muffled hearing, but that is a very unique side effect to aspirin typically. Ibuprofen, you don't really see that. Xylostine, what type of drug was that? It's like a nasal antihistamine. We don't really see that there. And acetaminophen also does not cause that. So again, aspirin alone. Okay. After failing OTC benzoyl peroxide, which medication would be next indicated for just acne with just kind of more facial involvement? And what is the next best option? Remember that stepwise approach we used to therapy. All right, so the next best choice in this option, probably if you went by the stepwise approach kind of in that table, the next best option is probably going to be a topical retinoid, right? Something like a Dapaline. Again, that's going to be a little bit better than just Retin-A because it's going to be a little bit more stable. It's not going to be photolabile like Retin-A is going to be. So again, think about, if you just have a little bit of facial involvement, OTC stuff has failed, right? So they're coming in, just like lab tests. You don't want to go with the most invasive kind of hardcore test you can find. You want to start with least invasive and kind of gradually work your way up. Now, if this had been more diffuse disease, what might I have recommended? Probably doxy at that point, right? So more diffuse disease, you tend to go more systemic antibiotics. If they had failed Adapalene, what could you go to next? You could try topical antibiotic. At that point, it's probably plus or minus if you want to go to systemic antibiotic. I probably wouldn't fault you on that one. But yeah, topical antibiotic could be another option there. When would hydrocortisone be used? Yeah, probably not for acne necessarily, unless it was like really, really bad inflammatory. You can use that for like an acute exacerbation, maybe, but it's usually not very common. If anything, that could actually worsen acne in some cases due to the fact that you're having immunosuppressive effects, right? So you wouldn't want to do that. What about lithium? Yeah, it actually causes drug-induced acne, so it would be something you would definitely not want to do. Unless you happen to diagnose some bipolar disorder at the same time, maybe. I don't know. Does that make sense? And go by stepwise approach. See what they've failed already, and then you can kind of decide what to go to with next, and then see, again, disease involvement. Look at, if we come in and said, hey, the patient comes in for acne, they failed OTC stuff, and now they're pregnant. What would you want to do? I mean, it's like, is the acne that bad? Like, do you just want to hold off maybe? Maybe hold off until the baby's born? That's one option. Maybe topical antibiotics might be a decent option, right? So you don't necessarily want to jump to systemic drugs, because again, limiting drug exposure to the fetus is probably going to be in general a good thing to do, right? Limit unnecessary exposure if you can. So again, that would be another difficult case. If you talk to a dermatologist, they might have a different answer than I would. But that's kind of the general stepwise approach. So look at your patient, look at what they've already tried, what's worked for them, what hasn't, and then you can make a decision what to go with next. Okay. Which medication can result in Ray's syndrome when given to a child with viral disease? Have you seen that movie with Johnny Depp's like Black Mass, I think? Oh, yeah, that's actually, there's a case of Ray's syndrome that actually shows up in that movie.
What?
There's a case of Ray's syndrome that shows up in that movie. It's actually pertinent to the story. Yeah, now you're like, oh, I'm really intrigued. I should go watch that movie. I would not watch it. It's very depressing. One time, me and my buddy, we were going to go watch The Iron Giant, which is going to be in theaters, and then they said that Iron Giant wasn't playing that time, so we were like, okay, well, I guess we'll go see this Black Mass movie instead. Not nearly as uplifting as the Iron Giant would have been. Oh boy, that was a bad decision. Okay, so right, so aspirin's the big one here, right? So you avoid aspirin when you have children less than 16 who have a viral disease. Even if you're not sure, I would just avoid aspirin for the most part, right? You can use Tylenol, you can use ibuprofen; those are all fine. But aspirin I would avoid if they're less than 16. Okay, guaifenesin you probably wouldn't use for fever anyway, right? Because we use guaifenesin for. Is a mucolytic, right? Good. All right. A mass of pills in the GI tract is known as what? The bonus question. It's good trivia if you ever, are at a bar on a particular night and need to answer a question such as this. Yeah, so that would be a pharmacobezor. I made up tabletobezor. That's kind of funny. What's a phytobezor? Yeah, it's like plant matter that gets, so sometimes you can have like over vegetable consumption, or if they have like pica or something, they're getting plant material that can form a phytobezor. What's a trichobezor? Hair. Ugh, like eating hair. It's disgusting. But yeah, you can see a really nasty hairball that gets caught in the stomach essentially, or the GI tract, and they might have to surgically pull some of the stuff out potentially. But yeah, pharmacobezor would be a mass of pills. So if you had someone like overdosed on a big bunch of pills and they all conglomerated together, that would be a pharmacobezor. Right, so no points for that one. It's just trivia.
So is there a worry of that coming apart and kind of causing some sort of systemic reaction or overdose?
So we do worry about that. Especially aspirin's a common one that will form a pharmacobezor. It's not super common, but it can happen. And basically, you'll have parts of it will break off, and then they'll start to absorb, because once the surface area increases, they'll start to absorb that. So that can be a big concern. And so sometimes we'll use things like activated charcoal to help kind of bind it all up, so that way if it does break off, it'll just get bound up and not be absorbed. So, yeah. Okay. 2 more questions. Which of the following medications has coverage against Pseudomonas aeruginosa? I have to look up how to spell Aeruginosa every time. All right, so look at pseudomonal coverage, right? So looking at the cephalosporins, which one would have pseudomonal coverage?
Fourth generation.
Yeah, 4th generation in particular. Is there any 3rd generations that do?
Yes.
Which one?
A lot.
Not a lot of them. No, ceftazidime is really the only one in that group. But again, we don't use it very frequently because you see a lot of resistance to that one. So again, I would not put that on a test question for you guys to remember that, because it is something we clinically do not use but the rarest of circumstances. Cefepime, absolutely though. What other cephalosporins? Yeah, that ceftaroline, and there's another one. Yeah, that ceftolozane. Those all have pseudomonal coverage. What's interesting about the ceftaroline? Yeah, it also has MRSA coverage there as well, so that's kind of a unique thing there. Which penicillins would cover Pseudomonas? The anti-pseudomonal penicillins, yes, which would include? Piperacillin, tazobactam, right? So that would be the one in that category that would cover that. Linezolid would not cover it because? Only gram-positive coverage, so no pseudomonal coverage there. MRSA, though, for sure. VRE, absolutely. VRSA would all be covered there. And then Bacterium does not cover Pseudomonas, but it could cover MRSA, yeah. So this is why you would use it for more like skin infections and cellulitis, because it could get some community-acquired pneumonia, or community-acquired MRSA. Good job. Because so again, those kind of key, like kind of buzzword bacteria, so like Pseudomonas, MRSA, MSSA, C. diff, those are the kind of the big ones that to kind of keep in mind for kind of coverage specifics. Okay, and then which of the following has coverage against MRSA? Hopefully I did not give that away. All right, so what does coverage does Keflex have? Yeah, it'll cover MSSA. That's why we use it a lot for, we'll use first generation cephalosporins a lot for surgical prophylaxis. So if we're not using cephalosporin, it would be like the IV kind of version of that. And cefazolin would be the cefazolin, some people call it that. I don't really know which one's correct, but either one would work there as well for surgical prophylaxis. It's kind of your go-to IV one. Keflex is a good PO option. But yeah, so Keflex would be a good option there to cover MSSA, but does not cover MRSA. Again, polymyxin B and gentamicin, mostly going to be gram-negative coverage almost exclusively. Clindamycin, though, will cover MRSA, right? So think about Clinda, think about Bactrim, think about Vanco, Linezolid, Dapto, things like that. Right? All right. So the winner is USA #2, I guess. The Ivan Drago of the class. Where's Mother Russia? Very nice, very nice. Pseudomonas. Nice. And then carbapenem lover. I think you guys might be cheating back there. It seems a little weird to have all the winners right in the back of the one area. Okay, so the free answer is B. Okay, any questions? Does that make you guys feel a little bit more comfortable? Is there similar questions? No? Well, it'll give you a place to start studying, hopefully. Again, I tried to make it, it's probably close to 50% antibiotic stuff, and then 25% derm, 25% ENT, right? Because again, those antibiotic stuff is kind of the biggest portion of that. Again, 50 questions, 4 answers, the standard kind of thing. Any questions I can answer for you guys? Yes, sir. No, you could probably get away. I don't see doxy used very frequently. Theoretically, it could cover it, but more often than not, you typically see like an augmentin or a unison being used in those cases. Maybe it doesn't have quite as good anaerobic coverage as you might want in that situation, but I can't say that I've ever seen doxy being used. Well, it's not necessarily synergy. It's just that the beta-lactamase inhibitor kind of just lets the other one work better. So it's not like they're both kind of having activity there. But yeah, just in general, in order to get that kind of coverage you need for those kind of gram-positives plus the anaerobic stuff you find in the mouth, like that typically is kind of our sweet spot for coverage there. Doxy you'll see used a lot for like animal-borne diseases, or if you ever have like a bioterrorism attack, like you'll see a lot of doxy being used for like anthrax and things like that. Fluoroquinolones are another big one you'd see used. So like the CDC has like national stockpiles of different medications, and so they'll have some antibiotics ready if there was ever a chemical attack or something, or a biological attack, I should say. Not to put a downer on everyone, but any other questions? All right, I'll be out doing site visits the rest of the day, so I will not be here. And I will not be here tomorrow, but the rest of the week I'll be here. So, or next week I will be here. not be here on the weekend. But next week I will be here. So if you guys need anything, please email, stop by, whatever you need to do. Okay? Yes, ma'am. So cefepime, ceftazidime technically does, but we don't use it often clinically. And then your ceftaroline and that ceftolozane, so those 5th generation ones would also cover it. All right, well, if nothing else, I will see you guys next time.